Hello, I'm Dr. Vlad Maletic. I'm a clinical professor of psychiatry at University of South Carolina School of Medicine in Greenville, South Carolina. I wish to welcome you to this program titled Episode 4, Optimizing Management of Schizophrenia, the Role of Coordinated Care. Uh, our esteemed guest today is Dr. Deanna Kelly. She's Empower Professor of Psychiatry at the University of Maryland. Welcome, Deanna. I'm glad that you were able to join us today.
Great. Thanks so much for having me.
So, our audience probably already know this, but I will repeat it. You are a master clinician, and engaging patients suffering from schizophrenia, especially if they're in psychotic state, may represent some challenges. So please share with us, what is your approach to shared decision making when talking about the treatment plan with your patient suffering from schizophrenia?
Yeah, thanks. This is a great conversation to start off with. So I think it's really important from the beginning when we talk to our patients or when anyone's speaking to with their patients that we have this common purpose in mind. We want them to succeed, right? We want them to succeed at treatment, we want them to succeed at their adherence to treatment, and we want them to succeed in their recovery path. So I think it's really important to set the stage really early on in this shared decision making idea. So, this idea of shared decision making is that it's a process. Like, this is a conversation between myself and our patient. So, my job is to provide, the full information, their medical information that they need to help make a successful decision together. But they have a job too. And their job is to state their preferences, to sort of understand what's best for them and relay that information. So it's our jobs to be able to have that conversation and make sure that we're both going back and forth. And I think that we have to make sure there's options. Like, this is not me saying this is what you should do, but in fact that here's what some of the options that we have. Here's what that I'm going to lay out for you might be great options. But this isn't just often the patient and myself, but the shared decision making process could also include other clinicians. My background is in psych pharmacy, but also the physicians, the pharmacists, the nurses, and we don't discount family and friends in that decision making too. So there's this idea that they have to make an informed decision. And so if we do our best job in making this a positive conversation, like, what do you hope to be doing in the next few months, or what are your top priorities that we can help you achieve in the next few months? And so that using all of these techniques, and including things like the idea of motivational interviewing, this is sort of a counseling approach where we can help them by being non-judgmental, listening, having empathy, resisting saying all the time what we think, but listening so that we can help them help understand what they're thinking and what they're bringing to the conversation. All of these, I think, are really important for setting the stage, for being able to make the best decisions, and together making some choices for what the treatment plan is going to look like.
So it sounds like setting the goal is a collaborative task here, right?
Absolutely.
You have some idea what the most appropriate approach, but you actually engage the patient, help them set goals. And also, amongst those goals, from what I'm hearing from you, uh, it's not only getting rid of symptoms, but it is also optimizing their quality of life and their functioning.
Yeah, absolutely. Absolutely.
So, does that conversation usually flow pretty easily, or have you encountered some challenges while having these
There's always
conversations?
some challenges, but I think it begins with rapport. I think it begins with making the person feel comfortable. Like, I'll often talk to them first about what's going on in their lives, or something that they really like, or hobbies that they have. And I think within a few minutes, I've been able to find that you can have rapport pretty quickly, if you make people feel like they matter and their voice matters and what they're talking about matters. And I think all that sets the stage. But there always are challenges. But I think making sure you feel comfortable with each other is one of the things that help set the stage for a good conversation. But this might take time, right? We don't can't always have this conversation in one setting. We might start a conversation and then have to have it another time and another time. So it's like I mentioned at the beginning, it's a process sometimes. of this shared decision making model. Yeah.
So again, thank you for your very detailed answer. So let us say the rapport is established, relationship is there, patient is engaged with you. So what are some of the considerations that you have when you are assisting your patient in creating a treatment plan?
So I like to think of it that we should be looking for the right medication for the right person at the right time. And really, it's an older term. We've talked about personalized medicine or precision medicine, often meaning like looking at the genetics and help that predict. But really, I think of it as this idea of the personalizing treatment. We're trying to find the best the treatment for each person. And so having that conversation on what we think was the best treatment options based on a variety of measures and outcomes, I think is really important. Some of those inputs that come into the equation that we like to talk about are what do you expect? What matters most to you in this conversation? And that could be things like, does it matter if you're on the most efficacious, the drug, the medication that shows the most efficacious, but might have more efficacy, but might have side effects? Or, should we look at some of the medications that might have a few side effects and think about what might be the best that might be minimize or prevent side effects from occurring? So there's lots of preferences that go into this equation. I mean, sometimes, and we could talk more about it, but there are, I mean, all medications have the potential for side effects. We want to prevent them and we want to minimize them. And we don't want people to have side effects that really are going to get them to stop taking medication. So things like weight gain or dry mouth or restlessness, sleepiness, sexual side effects, all of these things, we can talk more about it, but come into the equation and we can really get to know them and talk about what matters. But other things that matter in the equation are not just those, but what have they responded to before? What have they failed before? How many trials have they had? And then things like, what are the barriers to taking medication or getting your medication? What matters to you? Is it too many times per day? Is it when you take it in the morning? Is it taking it at night? Do you have to take it with food? Do those things bother you? Is it it's difficult to pick up? Like, what are all the barriers? And that helps decide if we want to select an oral or over long acting or something that's dosed twice daily or once daily. So I think knowing what their barriers are, knowing what matters to them is really important. Also, I do think about comorbidities. What do they have? Obesity? Are they a smoker? Are they a substance user? Do they have hypertension? Do they have hyperlipidemia? I mean, you can you know all these. We could go over all of these comorbidities, but we do, if we are picking the best medication for the person, we want to take all these into consideration. So those are a lot of the things I consider when we're individualizing a treatment plan. I'm sure there's other things that I forgot to say there, but that you might even consider. But I think those are some of the cores.
Something that came to mind and something that I researched for a CME project that I was doing. Uh, Individuals who have schizophrenia very commonly have other psychiatric
Mm-hmm.
comorbidities.
Mm-hmm.
So, about 80% of the individuals who have schizophrenia have other psychiatric comorbidities. So, unfortunately, there is very little controlled research into how are we to combine medications to address some of the comorbidities. So I'm just curious about what your approach is. First, getting information about comorbidities, and then how would you approach treatment complexity?
Yeah, absolutely. No, I think that this is really an important point because we want to treat the whole person and there's lots of comorbidities and you mentioned psychiatric and I think I didn't mention that, but that's really, really important. People have anxiety, especially coming out of COVID. There's a lot of anxiety out there. There's a lot of people that have depressive symptoms or what we would think of as a mood component. But there's other things like past trauma exposure where sometimes people have more dissociative symptoms, but and so there's a full gamut of even traumatic, like post-traumatic stress disorder. We'd be remiss if we left the whole picture at just their psychosis. And we have antipsychotics and treatments that work for their positive symptoms. We do need treatments for negative symptoms of the illness. We do need treatments for cognitive, which we don't have a lot of options, but we do have treatment options for some of these other targets like depressive symptoms, et cetera. So we should be making sure we go through the whole picture. And that's what I like to think. Okay, we're talking about your target treatments. And I don't often say your treatment for schizophrenia or a treatment for depression. Like I try to think about the target symptoms that you have and what can we do to help those target symptoms. We have medications that could help you with those voices that you're hearing or the distress that you have. We can help you. We have therapies that help you, cognitive behavioral therapy. That's an important point too, not just focusing on like, we're going to treat your schizophrenia or treat your depression. No, not these labels, but we're going to treat what matters to you. And we have targets that we can kind of bring out, and we have things that can help you. So I think it's a really good point you brought up.
So it sounds like your approach is to paint a complete picture,
Mm-hmm.
right? As you said, not only schizophrenia, but be more detailed. Look at specific symptoms of schizophrenia, not only psychosis, but cognition, negative symptoms of schizophrenia, but also comorbidities. You mentioned anxiety, you mentioned depression, you mentioned PTSD, and there are pharmacologic choices
Mm-hmm.
that can address this diverse symptomatology. And then it's a matter of providing a balanced information about efficacy and safety. But is there a role for non-pharmacologic components in the treatment
Oh,
plan?
absolutely. I mean, most of our evidence base is in the pharmacology side of things. And in Europe, we use non pharmacologic sometimes more than we do here in the United States. But we certainly think that therapy within the context of our patients with psychosis is really important. We use CBT for psychosis, and we focus really on the distress and helping them feel better and function better versus approaching it like we're going to treat your schizophrenia. And I think our patients really appreciate that. But in the scheme of like what we're thinking about when we're thinking about how to treat people, how do we make sure, and we can talk more about it, but how do we make sure that they're adherent to their treatment? So there's approaches that we take also that are not really therapies, but there are approaches that we take that really help people get to think about, when should I take them, how do I remember to take it, how can you help me take that? And so it's a holistic approach. It's not we can never just go into it like this is just medication, and medications are a mainstay, but you know what, we want to help people feel better and function better, and this is going to come with the quality of life side of things are going to be from therapy, from groups, from other aspects of their care as well.
And you mentioned adherence. Groups can be also used to monitor adherence, right?
Absolutely.
Amongst other things.
Right.
So there are certain things that can be added to enrich this treatment
I
plan.
think it's
Uh,
remiss if we don't have the whole picture in there. I believe non-pharmacologic treatments are underutilized today, and we should do better at that. Yeah. Yeah.
you have mentioned on a couple of occasions side effects and medical comorbidities. How do you broach this topic with your patients, and how do you like to discuss this? Uh, because some of the medical comorbidities might steer us towards a certain more specific pharmacologic approaches. Obviously, we don't want to aggravate their medical
Yeah.
comorbidities. So, just share with us briefly what is your approach? Which adverse reactions do you mention? Do you prospectively monitor those in treatments? So again, you have rich clinical experience. Please share some pearls with us.
Yeah, I mean, how I think about it is that there's all medications have the potential to cause some side effects, and we want to prevent them and we want to minimize them. We want to pair the right medication for the right people, and we want people to feel like that we really are thinking about that they care about. We're not just throwing something at them, but we really care about that. And the fact of the matter is that side effects are fairly common. There was a study Don Belligan had published in 2020 coming out of COVID, and a survey, and I think it was somewhere like 98% of people with schizophrenia reported that they had side effects. And I think like 80% said that impairs their social interactions, their work interactions, their relationship interactions. And so I mentioned before that there's a variety of side effects. I mean, we have things, and I think from that same paper, I was going to say that some of the side effects that were most bothersome were weight gain, sexual dysfunctions, trouble concentrating, some of these things that we know happen, but different antipsychotics have different profiles. And so I like to think, like, talk about what matters to them first, and then sort of talk about like what we could expect as potential some side effects. Not that doesn't mean they're going to get it. I want to make sure I say that. I always say that it doesn't mean you're going to have this side effect. There's a potential for it with this one medication. So let's like think about what's going to be really important for your care. And there's I don't really talk talk too much to my patients about there's older medications and there's newer medications as classes, like the first generation and second generation. We certainly know that there's differences in the profiles, but I really just talk about, like, here are the options amongst all the agents that we have. There certainly are new medications on the market in recent years that don't have some of the side effects that we've had before. Like, they don't have weight gain liability, and they don't have the movement disorders, and they don't have diabetes as a side effect. So, like, we have some options now where we can start people, and we don't even necessarily have to worry about them gaining a lot of weight if that was a major concern associated with their care. So I really just think about it as, what matters, what are we striving for, and like, what do we want to prevent and minimize, and then what would be the best treatment option.
Okay. Let's say the treatment adherence is of concern. There are long acting injectable
Mm-hmm.
medications. Tell us about the conversation that you may have with the patient where you're discussing pros and cons of oral treatment versus long acting
Yeah,
injectables.
I actually think that, I mean, I like the idea. If we think a long acting is a good idea, and in many cases I do, I like to have that conversation from the get go. That this is something that I think is important, because if we have the mindset that this is something that we reserve for later on when they're not doing well, or, if they may be failing things, or something like that along those lines, then it really sets the stage that this wasn't our first thinking. So I like to tell them right from the get go that, what, we have opportunities to be on what we call long acting injectables, so that we could have, we don't have to worry about taking a pill or a capsule or a tablet every single day. And I think this might be a great option for you. Let's start, with, taking it orally, but let's keep that in your mind. Like, I know that you might not want ready to talk about it right now, but I want to tell you what a good idea this is. And I think that we do know that the long acting injectables have some improvements in terms of keeping people out of the hospital, decreasing relapses. There's actually some data to suggest that even mortality is less and suicide rates might be less. And even the fact that the less times we have relapses, we might have fewer or less gray matter loss in the prefrontal cortex. So there's lots of talking points in data we can get to if it's important for people to talk about. But I think setting the stage from the get go that we have options to help them to not have to remember, and remember to take their medication, is really important.
A more daunting clinical
Yeah.
challenge regarding treatment resistance versus pseudo resistance. How do you broach this topic with your patients? Many of them do not like to hear that they have treatment resistant schizophrenia. It almost sounds like psychiatric version of metastatic cancer. I mean, it frightens people to say treatment
Right,
resistant.
right.
So, what is your approach to patients who could be defined as having treatment resistant
Yeah, I
schizophrenia?
mean, we define,
How do you bring this topic? How do you discuss this with the
it's
patient
really good. It's
without
a good,
frightening them and distressing
yeah,
them?
it's a good point. I mean, in the research world, in the clinical world, we use these terms, and we have strict criteria for what treatment resistance is, and we use TRS as treatment resistant schizophrenia in our papers, et cetera. But I don't really think when we talk to our patients that it's really what we need to be talking about. Just like I said, we don't need to be talking about, let's treat your schizophrenia. You have schizophrenia. Like, sometimes people don't even acknowledge that they have it, but they do recognize the fact that there's things that they could receive treatment on. And the same is true with this idea of treatment resistance. I really think about, okay, we've had a couple of medications on board now. We've tried two things, and they haven't been right for you. Like, these haven't been right for you. We have lots of other options. So it's not the idea of that you failed, or, because in reality, kind of the medicines failed them. But I really talk about, these weren't right for you. We have other options. And when we go down the line and think about, like, what do we do next? Like, what's logically the next choice? I do really think that if people have treatment resistance, or in how we discuss with them, like, they're not on the right treatment, I do like to bring up clozapine really early in their care. And I talk about the idea that the guidelines, there is a first line agent for those people who have not had the right have not responded, have done really as well as we wanted to on the first two treatments. We do have something that works really well for people that don't do well in their first medication trials. So I talk about that as a first line agent for them potentially then. And so you can turn the rhetoric around from feeling like you're end of the road, last line, to knowing that there are some really good options for people that don't have the right treatment the first time around or the second time around.
And we want to make sure that it is true resistance
Mm-hmm.
in a sense. There was treatment adherence, as opposed to pseudo resistance, where it could have been an erroneous diagnosis, where it could have been the patient did not take their medication regularly.
Absolutely. And I think that's why the new guidelines, the treatment resistance guidelines are important, because it really does point out to us that, treatment resistance, the aspect of it, just like you said, is that we might be missing adherence. And we don't mistakenly think someone is not doing well when they're not adhering, because we all have patients who that we know they're not taking their medications. They might be telling us they are, and they're trying to convince us they are. We know they're not. When they do, they get well, and we can and if we just go along too long thinking that they are taking it when they're really not, we're doing a disservice, because it's really becomes a pseudo resistance issue. But you're right also that the diagnoses sometimes contribute to that, so making sure that we have that right diagnosis does help. But yeah, pseudo resistance is something we should all pay attention to and not just assume they're really treatment resistant.
Deanna, thank you so much for this wonderful discussion and for sharing your clinical wisdom with our audience. So it's very much appreciated. Thank you very
Thanks
much.
so much. Glad to talk to you.
Thank you very much for joining us for this educational and interesting discussion. So please continue on to answer the questions that follow and complete your evaluation for this activity. Thank you very much.